first, I want to circle back to Dr. Nina Watson, because I'm fangirling over here because she doesn't know I follow her on Instagram. But Dr. Watson she's a board certified.
Awesome. I looked at your intro, I'm like, wow.
She's incredible. Board certified, fellowship trained, and she's real. This is true.
Right. Yeah.
Certified diagnostic radiologist. So that means she's skilled in all aspects of breast imaging, including 3D mammograms, where she'll talk about breast MRI, interventional breast biopsies, procedures. She completed her training at Columbia University and New York Presbyterian. She is on the board of national organizations. She is the CEO of her own enterprise with Dr. Nina Watson. She's a fitness expert in wellness, health, nutrition. Dr. Nina, thank you for joining us today. We're just so happy to see you. And I want you to go back for us. Before we get to the cancer, we got to do some things first. And what are the things that women need to know, I guess, about imaging for their breast?
Yeah, so one of the first things to remember is, there's all this talk about mammograms, but it's like, what is the goal of a mammogram? Mm-hmm. Sometimes, unfortunately, some women may feel the goal is to prevent breast cancer. That's not the goal. The goal is to find a cancer if it is present as soon as possible, when it's as small as possible, so that it's the most treatable. A mammogram itself uses X-ray images to take images of the breast. The breast tissue is placed between two paddles, spreads the tissue out. Images are taken that help us to identify any abnormalities. And particularly, we're looking to see if there is breast cancer there. For a number of years, we've had what we call just the 2D images. What we've had now recently developed are 3D images. The difference between the two, I would describe as the 2D images are looking at the breast tissue like a book. Mm-hmm. A 3D mammogram is like opening up that book and flipping through the pages. All right. So for the same exam, for the same amount of time, it gives us so much more information. There are two different types of mammograms. So one would be a screening mammogram. A screening mammogram is just your annual exam. You're not having any problems, no issues, no symptoms. You come every year for that exam. The opposite would be a diagnostic mammogram. And a diagnostic mammogram is a mammogram where there's something going on. Mm-hmm. Whether you're feeling a lump in your breast, you're having fluid coming from your nipple is beginning to stick in. With those diagnostic mammograms, the radiologist, a doctor just like myself, would look at the images while you're there, see if there's any additional workup that needs to be done, possibly also do an ultrasound in that evaluation.
Great.
And as far as recommendations, because we're going to get this question in the comments, the pendulum is swinging wildly back and forth about when women should begin getting their mammograms. What does the American College of Radiology have to say?
So the American College of Radiology, also the Society of Breast Imagers, which is the society of individuals like me, we recommend for women who have an average risk of breast cancer to begin their mammograms beginning at age 40 and to have a mammogram every year. Now, we are realizing that there are groups of women, which Black women are included, that are at a higher risk. And so we're recommending now also for all women to have a risk assessment, at least by the age of 30. And that's to determine if it may be necessary to start having annual mammograms or some additional type of imaging before age 40.
Yeah, well, the data says that Black women under 35 get breast cancer at twice the rate and die at 3 times the rate. So 40 is like too late for us. I mean, exactly. I guess the risk assessment has happened, and Dr. Hampton kind of talked to me about that a couple months ago. So we could talk about the kind of the mandate from Black surgeons, right? But, but still, that should be widespread. I mean, that's what our young women need to know, and can't be kind of dismissed by doctors when they come in at, in their late 20s or 30s and want to have a mammogram. They should be able to get it. Right?
Exactly. And there's also women who have, genetic mutations. We're realizing that in Black women, there's a higher number of women with genetic mutations than we once thought. We need to be able to identify, to pick up on those women and to get them into screening earlier. So that's important too. And that's why, having that risk assessment, at least by age 30, it's important.
Important.
Yeah, I think that's huge, because we began high risk screening at my hospital because I had family history of breast and ovarian cancer. And I got to my hospital and we started a breast program. And I said, well, what do you do for the high risk people? And they kind of looked at me. I said, so who's keeping track of those women? Who's making sure they get mammograms and MRIs? And so we implemented, with the help of some industry partners, programs to routinely screen. Every year when a woman comes in, we go over the thorough family history and we offer genetic counseling if necessary. We can do it virtually now. We can mail out a kit for genetic testing. But every year we're asking about their family history and trying to give them a quantification, a calculation of their risk. And I don't know how many people watching actually know that you can quantify, you can get a number. And usually it's a range, but you can actually know what your percentage of 5-year, 10-year lifetime risk is for breast cancer. And so for everybody watching right now, I'm asking, do you know your number? What's your percent? And if you don't know, you need to go to your gynecologist, go to your PCP, go to your breast surgeon and ask those questions. Dr. Hampton, would you chime in here and talk more about the importance of knowing that family history and doing that risk assessment? Because I think in years past, maybe 10 years ago, some doctors were doing it and some weren't, but now it's kind of almost a mandate, right?
Right.
Yeah, absolutely. And, I think there's kind of two parts to that. One, there's how many of us really know our family histories.
Right.
I can't tell you the number of women who come in and, they say, no, I don't have a family history. And then we diagnose them with breast cancer and everybody in the family starts talking about who had breast cancer and when. So we need to start those conversations in our families, especially I know in African-American and Latina families, it's taboo to talk about health history, cancer, saying the C word. But, we need to do it if we want to save the lives of the future generations. So we really need to talk and know our family history and not just know what type of cancer was in our family, but at what age. Because even beyond breast cancer, we tend to get a lot of cancers, colon cancer, prostate cancer, name it. We usually get it early. So knowing the age is so important so that we can start doing the screening and doing the risk assessment. Because adding those numbers into the risk assessment, which we can plug all these numbers in and it spits out a number to give us your risk, having all that information is important so that we can know who to screen appropriately.
Yeah, Dr. Hampton, the Ad Council did this study 2 years ago, but right before the Komen people did their Know Your Girls campaign, which is so good to know your girls. But 92% of Black women said that they were aware of breast cancer. 25% said they talk about it. 17% act on it.
Wow.
That's scary.
That's scary. We don't talk about it in our families. And so we're all about know her story.
Well, let's chime in. Let's hone in on that though, because what is the fear? Because I'll tell you, I didn't know what my mother died from till I was almost 29, and she died at 29 of ovarian cancer, and it was just something down there, and we didn't talk about it, And where did that come from? What do we do? How do we combat that in our families and have those tough conversations? That maybe show that we didn't know as much. Maybe our mother died and we didn't know what she died from. How do we piece that together and start to make our conversations look a little healthier in our families?
Yeah.
I think it's generational. I feel like the younger generation get it and they're trying to really pull the information out from the older generations. And I think, really just communicating to the older generation that this is about love.
Right.
Your health history is about love for your family.
Right.
Wow.
Introduce Shanta.
I was just going to say, I want to get you in here. You go ahead, Ricky.
No, Shanta is a fierce force to reckon with and has been in this space for many years, helping women with everything, right? With everything about their lives. So I'm so glad you're here. So tell people what you do better than me, but she just is like, I just see her as like, when you need help, you call Shanta.
I love that. You sound like Batgirl or something, or like a superhero.
Let me go get my cape. Yeah, let me go pull my cape out the closet. Right? Well, needless to say, I'm excited about sharing this afternoon. I don't know if you ladies saw my post, and I said, well, we're about to go into the Zoomosphere with some amazing women, because I think it is so important going back to the last question is, how do we do this? What do? We start the conversation. And I think we do exactly what we're doing today, is really bringing this conversation and meeting women where they are. This afternoon, I have the pleasure of sharing resources, because the one thing that even in my work and working with communities that they always say, well, I don't know where the resources are, or I don't know how to connect with those resources. And so I'm sure that all of the doctors on the panel, you probably hear this all day and night. And so what I want to do is just spend some time today kind of sharing some resources that everyone who's watching this, as well as all of you, as you're interfacing with your patients, your community, et cetera, you can take them something, you can take them a resource, right? I think Dr. Hampton touched on earlier, if this was about a Gucci bag, if these kinds of things, we'll make it a priority. We can always tell women where to get the best Remy. We can tell them where to find the latest stilettos. Now you're going to be able to tell them where they can find some breast cancer resources.
All right now. Absolutely.
Wow, I love that. Talk to us more about some of those reputable resources.
So hopefully everyone can actually see my screen here. So great. So Patient Advocate Foundation, we're a 25-year-old organization that's been at the front line of really working with women and men and the entire community around helping folks with chronic, complex, debilitating conditions really navigate those barriers to care. And we were actually birthed out of a tragedy. So our founder, Nancy Davenport Enos, lost her dear friend because her insurance would not allow off-label usage of a therapy that could have potentially saved her life. And so from that, as Cheryl battled with her own breast cancer, at her point of death, Nancy said, no other woman should ever lose their life because of an insurance-related decision or an inability for them to be able to have access to novel therapy and to care. And from that, almost 25 years later, here we are as an organization served over 1.4 million individuals across the entire country. So this is just kind of a statement from our CEO, and it really level sets, because I think oftentimes we don't realize that women, especially women with breast cancer, especially Black women who are at risk of breast cancer, we're starting from a very different place, whether it's because of our social economic conditions, whether it's because of family history, or even if it's from just emotional and physical exhaustion for feeling like we have to fight for everything, including access to screening and early detection. And so that is why for us as an organization, we want to make it easy for those individuals who have a variety of different chronic conditions to be able to access resources pretty easily. So today, what I want to talk about is a lot of resources that we as an organization have kind of cataloged, right? I'm a social worker by training, and we live by that Black file cabinet. And we know many times you pull out that Black file cabinet and you looking for resources and you reach the back and you realize that the person who's sitting across that table from you has more need than your Black file cabinet can address. And so what I want to share with you is one of our signature resources, which is our National Financial Resource Directory. What we've actually done is pull into one online directory hundreds of resources from across the country. So we have resources in this online database from all 50 states, a variety of chronic conditions, including breast cancer. And for those who have other chronic conditions, we have resources in this tool. You can search by asking 4 questions: age, your state you want to choose, and medical condition. You can also choose the tab. If you look here, there's one tab for uninsured and another tab for underinsured, because many of us know that there are even individuals walking around now that have insurance, but the insurance that they have is not sufficient to really cover what they need. So what we wanted to do is put in one searchable database all potential resources to help folks find financial and other resources that they need. As a pullout, we've actually built out 2 resources specifically for those living with breast cancer. And that's actually our breast cancer resource directory. So you don't have to go all over town. You can actually go to this online resource. It has the same search features where you would enter your age, you would enter the state that you want to search for. You would also enter breast cancer. And it allows you to search what we call service areas. Service areas can include everything from looking for financial resources to cover utilities, to financial resources to help with copay assistance, for financial resources to help with childcare, to even scholarship information for those who may have had breast cancer or any other chronic condition and desire to pursue their education. So this pullout is specifically for breast cancer resources. Along with that, because we also realize that the unique needs of those who have metastatic breast cancer. So along with that breast cancer resource directory, we've also embedded resources specifically for women who may be living with metastatic breast cancer. The search features are all the same. You go in, as you can see in this example, the age that was entered was 18 to 26. This person wanted to search resources in Kansas, and they were looking for emotional support resources and fertility resources. And just by answering those 4 questions with this one search, this person was able to identify 116 resources. Now, if you think about it, how long in our old antiquated file drawer days would it take us to find 116 resources? We will become so frustrated in the process that we just give up. And so many of us know women who've just given up because they're so exhausted from just trying to find these things. And so that is why, as an organization, it is so critically important for us to take the resources that our case management team taps into and puts them into these types of online resources.
It's great, John.
So go ahead.
This is great. This is great.
The other one I want to point out too is that copay relief, because one of the things we often hear from patients is the difficulty they have in terms of financial challenges in being able to pay for medication. I think if I was to ask anyone who's on this Zoom, tell me if you know someone or even had your own experience where you've had difficulty paying for therapy, right? We would all raise 2 hands, a foot, and probably an elbow, because we know that that's a very real experience. And so because of that, Patient Advocate Foundation, we also offer or administer a copay assistance program. This program has a variety of different copay funds, and it helps to offset those copay related expenses, including in the breast cancer space as well. This is just an example of what the breast cancer information resource looks like. It tells you what the maximum award is each year. A person can only apply once in a 12-month period, but there's no limit to the number of times that they can apply, so they can apply annually if they would like. We open and close our funds daily, so I encourage anyone to check back frequently. It takes you only about 7 to 10 minutes to complete the online application. And at the conclusion of your application, within 2 minutes, you will know if you've been approved. So again, not only do I want to make sure that we are aware of these resources, I also hope that you go away with an understanding of the ease that we've tried to bring forward and helping you access these resources as well.
And look at that, $5,000. It's not, it's a lot of money. It's good, that's
incredible.
That's pretty incredible, right? And we get calls every day. I was hoping Abby would be on because she called and asked for you, and when we send it to you guys. So
make sure she's watching. This is incredible because, I tell my patients, nobody budgets for breast cancer. I don't care how much money you have.
Right.
I don't care what your savings and your stock portfolio looks like. It doesn't matter how much you make, what you do. Nobody budgets for this. And whether it's, showing up for chemotherapy and getting slapped with a $10,000 bill before you get your first infusion, or if it's death by 1,000 copays, this is so important because I think it's one of the reasons why people feel helpless and why there's an issue with compliance sometimes as well. Because, when you got to choose between your weekly or your monthly groceries or your copays, the choice becomes a lot different and a lot more real. Than just, let me be compliant with this, prevention or this treatment that may prevent a breast cancer, that I might not get again. And people rationalize it that way. And they rationalize away their chances of success sometimes. So this is huge. But I want you to finish telling us the rest of the information, and then we'll get to some questions.
That's actually a perfect lead in here, right? What did COVID show us? COVID showed us that it had no respect of person, number one. And it also showed us that it could be an enormous disruptor, especially for folks who are already experiencing episodic engagement with the healthcare system. Like you said, no one budgeted for breast cancer. And for us as an organization, we understand that when someone is living with a chronic condition, we have to account for those things that happen outside of the healthcare system. They still have to have utilities. They still have to have a place to stay. They still have to be able to eat healthy. They still have to have reliable transportation, because all of these factors left unaddressed prohibit their ability You can be making the best treatment recommendations in the world, but if we're not accounting for these social needs outside of the context of health, we're setting up everyone. We've made healthcare available, but we're not making it accessible if we're not accounting for those things that impact one's life outside of the healthcare system. And so as a result of us, with everything that happened with COVID, we realized that we have to be able to think about these other conditions. And so what we stood up was our COVID care resource. And I raised this because I encourage people to think about, as you're searching for breast cancer resources, think about resources that may be available under some other umbrella. And so that is why we actually stood up this COVID care resource. And even here, what we've done is for all of the resources that we've been able to catalog to support individuals who were directly or indirectly impacted by COVID, again, we put them all in one place for someone to be able to come to and look. And actually, as a part of it, in the resource center, this is just an example of some of these resources that we pulled together, because once COVID came on board, we weren't just dealing with patients around health insurance issues. We were dealing with patients around applying for unemployment, people who are now uninsured and in treatment, right? It's like, so now what do I do? And so again, we can't minimize or can't ignore the impact of all of these outside of healthcare types of situation will have on one's ability to be able to actively engage. Mm-hmm. And as a part of that, this is kind of how we design our case management work, especially with open enrollment being right around the corner. A lot of people are anxious and panicking because insurance is complex. It's not something easy to understand. So as people go away from today, I want them to understand if they felt like, all of this is too complex. I don't know how to access these resources. I don't know how to connect. I want this to be the last day that actually be the phrase that you murmur, because you do have a resource that's available to you. All of the support, all of our case management support, all of the resources and services that we provide as an organization are available at no cost at all. Because we know there's so many other things in life that are cost prohibitive. We wanted to make sure that connecting people to resources is not. So here's the contact information. I'm going to be sharing this. I'm sorry?
Can we put that in the chat on Facebook? We'll put all this in the chat.
Sure.
Yeah, you may need to screenshot that and we can yep.
I will do whatever y'all need me to do to make sure our sister, girlfriends, and cousins know about these resources.
And this is national, these resources. It's national, right?
We serve all 50 states and U.S. territories. So if someone has and we still use telephone numbers. So if somebody can dial or if somebody can click, they can connect.
I love that you said that, because so many folks are having difficulty in the age of technology. We're assuming that everybody has access and everybody knows how to utilize all that technology, but some folks still mail in checks. Some people still go to the post office. Some people still dial numbers and do things by phone. And it's so important to have these resources available, because you don't know how to use them till you need them. It's not like you practice this, And while you stop sharing your screen, I want to throw out some statistics and get Dr. Hampton and Dr. Watson to weigh in. So there's been some studies that are showing that COVID has resulted in massive delays in screening, right? And so when you look at breast and cervical cancer screening, since from March, it was down 90% in the month of March. And by July, we're still down at least 27 to 30% from where we should be. So 285,000 missed mammograms, right? Dr. Watson, what does that mean to you? How do these women get caught up, and what are we expecting? And Dr. Hampton, what are you seeing as a result of these delays?
Yeah, what we're asking now is yes, we know that for a time for COVID, a lot of the imaging centers were actually closed for safety concerns. But now we are asking for women to please come, please schedule your annual mammogram. This is not something we want to delay. We don't want it delayed 6 months. We definitely don't want it delayed a year, because if there's any changes going on in that tissue, we want to be able to see it. So if you haven't had your mammogram for this year, please come, schedule it now.
Yeah, absolutely. I mean, yeah, we have been seeing some women who've been coming in because they, certainly delayed. And I think it's important for people to know that, those of us in the healthcare space, we want you to come in, and we want you to come in safely. We've all got to work every day, and we're trying to keep our staff safe. We want to keep you safe. So we're taking precautions like spacing out appointments, extra cleaning. We were always cleaning before COVID, but doing extra cleaning. So I can assure you that the offices, the health arena, we've really made it safe for you to come in, because we realize that, there are still other health challenges that people are going through beyond COVID.
But money shouldn't be one of them. Money should not be one of them. And I think also people have to know that you guys are walking around in these gowns and shields, and you're doing everything to protect us from doing it. Because I read a study the other day that there will be 10,000 extra deaths because of lack of screening for breast and colorectal cancer. So in the next 10 years, which is crazy. So we need to be going, and we can't. So Shanta has taken money off the table for not being here.
So Ricky, let me actually add, because most of what we deal with will be women post actual diagnosis. However, I think you pointed out something really important, is that money should not be an issue, because each state has a breast and cervical cancer screening program that is supported by the Centers for Disease Control, Division of Cancer Prevention and Control, every single state. And those programs are designed to provide mammography screening for uninsured, low-income women. So every single state is operating a breast and cervical cancer screening program.
That's great.
And to add to that, there are places where you can go to utilize that. So I know here in the DC area, we have a place called Breast Care for Washington. We take anyone, whether you have insurance or not. We work very closely with our state breast and cervical program. So these resources are out there, and we really, really recommend. Some of the programs don't even use all of their money every year, which is ludicrous. So please, ladies, access these resources and use the money. It's there.
I was going to touch on that as well, how every state has the cervical and breast cancer database, for lack of a better term. I can remember, and I'm sure Dr. Hampton and Dr. Moe remember, how there was a problem years ago with women and cervical cancer, and how women were not following up after these abnormal pap smears. And one particular lab, which I won't in this area, I won't name that lab, was severely sanctioned and fined because they had so many women who had abnormal pap smears and they did not follow up. And it's the same situation here now, where, if you have an abnormal mammogram, someone is going to be calling you and saying, hey, what's up? You didn't come and redo this mammogram, just like with the abnormal pap smears. But a lot of women, I know so many women in this area, had no idea about Breast Cancer for Washington. And I remember we did a fundraiser open house through an insurance company that I worked for. And I know that Breast Care for Washington must have did a mammogram for every woman in Washington, D.C. and Virginia that day. And when they were done, they wanted to give us mammograms. So we think that there's no excuse, but there's always an excuse. How do you short of the new EMR programs, you have to check everything. She said she had it, but does the provider go that extra step to make sure?
I can speak to that too.
Internal medicine level. I'm sorry, Dr. Moe.
Mm-hmm. No, I think you're right. And there are checklists and there are hard stops in the EMR. There are incentives, even as far as, primary doctors checking on, you work in a medical practice before, checking those boxes and making sure beyond the referral, right? Because that's what we do. We say, oh, you're due for your colonoscopy. I'm going to give you a referral, and you give the referral, and what the patient does with it from there.
Right. What do you do? Like, what do you do? How can you, how do you put an end to that? If we knew the answers, we'd all be rich.
Well, I think it has to do with making accountability everybody's problem.
Absolutely.
You know what I mean? So when I see a patient, I may only see a patient who's a survivor twice a year. And so you better believe 6 months later, when I see her, I'm going to say, so how are we doing with routine and preventive health maintenance and screening?
Right.
And then making sure that I hand off to the PCP, I hand off to that gynecologist and say, okay, Ms. Jenkins is due for her colonoscopy, please follow up on this, and making sure they get the notes. And there's no, you think it would be easier with an electronic system, but communication is private.
It really isn't.
But Dr. Watson, I want to ask you, for the people who are afraid, because there's a lot of folks, and they're very intellectual, that are concerned about radiation associated with mammography. They're looking into thermography. They're looking into ultrasounds as an alternative. Help women tease out some of the realities on the amount of radiation from mammograms, and why 3D versus 2D. Even if there's a copay, what should they do? How to navigate that?
Okay. So radiation dose is always a concern. And myself, as radiologists, it's something that we tightly regulate, and we also monitor. We try to give the lowest amount of radiation dose necessary to achieve the best images. And when you look at the benefits versus the risk, the benefits of having your mammogram every year, beginning at age 40, definitely outweigh any risk due to a small amount of radiation dose to the breast tissue. I know that, some women are looking for alternatives. Recently, some people have been talking about thermography as a possible alternative.
What's that?
So they're using sort of heat images generated by heat to create images of the breast tissue in order to find an abnormality in that area. That is not a substitute for a mammogram. If you would actually
say that again,
it's not a substitute for a mammogram. It is not. And if for those people who are, wanting to learn more about it, actually, you can go to the FDA website. There is an FDA warning advising that it is not a substitute for a mammogram. Breast ultrasound, yes, it is a great exam. It's a great tool that we use, but it's actually complementary to a mammogram. The two work together to give us the most information, particularly in women who have very dense breasts. Breast ultrasound can allow us to be able to aid in finding more cancers, but there are some findings that are associated with cancer that can only be seen on a mammogram. So having a mammogram and having a breast ultrasound is great, but a breast ultrasound solely for women greater than age 30 would not be beneficial in finding and detecting breast cancer early.
So let's talk about the dense breast thing, okay? Because we tend to have more dense breasts as Black women, but how do we know that, right? Until you've had a mammogram. And then the numbers I thought say that if you do have dense breasts, you're 4 to 6 times more likely to get breast cancer.
Yeah. So
how do I know that I have them? And then what do I do about that?
Yeah. So one way, and sometimes it runs in families, you do have patterns of dense breasts. You would have your first mammogram, starting out with your screening mammogram. Mm-hmm. In some states, depending on where you live, when you're sent your letter of your results, it will include if you have dense breasts. If not, you can actually look at your mammogram report, mm-hmm. and there is always a sentence there describing your breast density. If you're unsure, based on that sentence, if your breasts are dense or not, you can either talk to your doctor, your gynecologist, or your primary care doctor, but there's also resources online. So with breast density, there's 4 categories. And it's based on the sort of ratio between your amount of tissue you have and the amount of breast fat you have. So you have category A would be a fatty breast, and that meaning that the breast tissue is mainly made up of breast fat. Category B would be scattered tissue. Again, those 2 categories, fatty and scattered, are not considered dense. Category C is heterogeneously dense, meaning you have a lot of breast tissue, very little breast fat. And then you have category D, which is extremely dense breast, meaning you have a lot of breast tissue, very less breast fat. With those 2 categories, on a mammogram image, cancers can hide in that tissue. So it makes the mammogram a little bit more difficult to interpret. In that case, we would consider doing some, additional imaging depending on where you're located. You do a breast ultrasound. Some facilities are also doing a breast MRI as a way to evaluate those women.
Great. Thanks, Dr. Monique, for showing the picture here.
Yes, exactly. The picture right there.
That's the words. I got you, Doc, because this is something, and it's different than when you go to your doctor and they do the exam and they go, okay, you have dense breasts, and then they send you on your way, and you're like, well, what does that mean?
Exactly. And if you would look at the images here, so you see the category 4, the extremely dense breast, you see a lot of white there. That's the fibroglandular tissue, the breast tissue with white. The dark areas, those are areas of breast fat. Mm-hmm. Well, breast cancer appears as white. So it can hide in those areas where there's a lot of breast tissue, making it more difficult to find. And then also, as Ricky, as you brought out, women with dense breasts do have an elevated lifetime risk of breast cancer.
So Dr. Hampton, when you do your risk assessments, can you talk about, can you identify breast density even on an early stage? So you really don't know until you've had a mammogram. But if you're a young patient or a young person and you have a history, can you identify that kind of in the risk factor stage so people can be aware of it and know that they should ask for 3D?
Oh, they've actually incorporated breast density into the risk assessment models that we use. So, we can look on the radiology report, and, some radiology centers are great about identifying that on the report. Some can still help us out a little bit better. But once we have that gets plugged into the risk assessment with family history, menopausal status, if there have been any hormone use, if there have been any prior biopsies that have shown something called atypical lobular, atypical ductal hyperplasia, and all that can be plugged in to create the risk number, the percentage.
Great.
And your breast density can change with time also. That's another important factor. So younger women tend to have more dense breasts. The breast tissue is more dense. But as we get older, the tissue becomes more fatty. So it also changes with time.
And Dr. Nina, we had a question actually on that very same thing, that if younger women have more dense breasts, but if their risk of getting breast cancer is higher than their counterparts, should younger women be getting screened with ultrasound? Is there any recommendation there from the society about that?
Yeah, so what we would do is, first we want to determine if they're elevated risk or if they have some type of genetic mutation. For those individuals who do have an elevated lifetime risk, then we would actually screen with breast MRI, those women. For women less than 30, if they come in with a symptom, lump in the breast, changes with the nipple, fluid coming from the nipple, the first step is actually to use ultrasound to evaluate the concern.
Mm-hmm. And I think that's a really important point too, is that if a young woman feels a lump and she goes to her provider or her doctor and says, I feel something, for that doctor to do an exam and not order imaging, especially in a young Black woman, especially if there's any family history, to not take that seriously, I think is almost criminal, and we need to find doctors who take us very seriously. And so if you happen to be watching and you have felt a lump and your doctor says, oh, no, don't worry about that, find a new doctor.
Well, I think the medical community has been so confusing when we talk about breast exams, clinical breast exams, because they've been telling our primary care counterparts not to do clinical breast exams. They're telling the general public not to do your own breast self-exam.
Why?
So I don't get it. I mean, I think if a patient comes in with a lump, or if a patient doesn't feel a lump and their provider feels a lump, I mean, that's a two-pronged approach in addition to doing a mammogram. I mean, so we're telling people, don't feel your breast, just get your mammogram. Well, by then, the mass or the lump or the cancer might be a lot larger than we might have found if we were doing an exam. So I still advocate for breast self-exam, breast self-awareness. I still advocate for clinicians. I certainly do a clinical breast exam and encourage my primary care colleagues to continue doing them as well.
So self-exam, how often? Every month, right? Like pick a day of the month If you didn't pick one, I'll remind you on the 20th and tweet you about it, but it should be every month, right?
Absolutely. And I think we have to take the fear out of that. I think the whole goal of doing a breast exam is learn your normal lumpiness. Breasts are going to be lumpy.
They're going to be lumpy.
All of us sitting here on this panel all have a different degree of lumpiness that's considered normal. So know your lumps. Learn where they are, learn when they change, if they change, and learn if you feel something that's like, that's not my normal lump, that shouldn't be there. Then you need to call your doctor.
Right. Ricky, to your question, the reason why is because of fear, because of over biopsies, and because people don't know what their breasts are supposed to feel like. And so what ended up happening was U.S. Preventive Task Force, I think, and ACS did some research, and what they found was that, one, there's no head-to-head that shows that a clinical breast exam or a self-breast exam actually saves lives, which there's some flaws in that study, but there's not been a head-to-head trial between that and imaging. So they said, well, we can't really say if it's helping, but it makes women anxious. Right. And if it's making people anxious, we shouldn't do it. Well, that's the wrong approach. The wrong approach, you diffuse the anxiety through education, through self-awareness, right? And so I tell patients, absolutely do it once a month and set a reminder in your phone. Your phone can go off once a month.
There's a bunch of
every day you pick. And if you're premenopausal, then, and it's, during your cycle, set it for 1 week later. Just push reset, remind me again in a week. And our smartphones will do this for us now. Yeah. But it's not a reason. Fear is not a reason to not do this work,
I also encourage it when talking to patients to do it once a month, and also not to assume. Even if you have a history of breast cysts and you've had ultrasounds before and they show breast cysts, if you have a new lump and it persists for 6 weeks in between your cycles, definitely come in, have us take a look at the area. Let's document by imaging that it is a cyst, because you can have cysts and a cancer can still develop in your breast tissue. And we don't want to delay things until that cancer is larger.
Great.
And also, I just wanted to point out, as someone working with women in the community, because there is still such great apprehension around women going into facilities, this at least empowers them to be able to do something. When we take that away from them, then if they never know what normal feels like, they never know when something there is abnormal. Right. So I think it's about, until women, we can say, come back, but I think the real reality is women are still going to be a little apprehensive. So giving them a tool or giving them something that they could do so they are taking some degree of action has to be meaningful.
I have a question. So prior to being diagnosed with breast cancer, I was a candidate to have a double mastectomy prophylactically. But the insurance company that I was forced to choose, because I had no insurance, refused to do it because they said that it would be hard. In the event that I developed breast cancer, it would be literally impossible to detect. So fast forward 6 months later, I still had my breast. I was diagnosed with breast cancer. So now I'm completely flat. What do I do in terms of checking my breasts every month? I know a lot of women in this area and a lot of women that watch our program are flat. What do you suggest that we do? Dr. Mo, Dr. Selena?
You want to take that one?
Still do an exam. There's still breast tissue there, even though you're flat. So still do an exam just as you would if you had breasts there. In fact, it's easier to feel because you're not having to, try and get through a lot of breast tissue. But yeah, absolutely. If you're flat, keep checking.
Thank you.
And I'll chime in and say, I tell my patients to check above their collarbone, below their collarbone. Feel the skin, feel the scars under the arms where those lymph nodes live, right under that muscle there where you stick your thumb in. Those are places that you need to be checking, and every woman should be checking those places. Your breast tissue goes all the way up to your collarbones. It's not just here down. It's not just the stuff that protrudes. All of this is all part of that exam, and we can definitely.
You didn't take it all out of me?
Well, so here's the thing. I tell patients it's like separating the Jell-O pudding cup, right? So underneath the skin's a layer of fat that Dr. Nina talked about, and then under that fat's a dense breast tissue. You can take that dense breast tissue out, but it's like if you take the chocolate layer off a pudding cup, you'll still see some chocolate on the vanilla layer underneath, right? you can never really scoop it all out because of the difference between them is so close.
That's why I check my lymph nodes, everything.
You gotta check it.
So we had Abby join us, you guys.
Oh my goodness. Hello.
Abby. And
Hi, I'm so sorry I'm late. Can everyone see and hear me?
Yes, we can see and hear you fine.
Okay.
So Abby's a newbie breastie. How'd you find your cancer, Abby?
I had a follow-up mammogram because I had a problematic mammogram 6 months ago, and 6 months prior, I should say. And so my original mammogram was scheduled for during COVID. It got pushed back. And so when I went in for the mammogram, there was some abnormal stuff on the mammogram. And so the doctor did a biopsy right then and there, and pretty much called me 2 days later to tell me that it was cancer.
So 6 months ago, you had a mammogram, and they said,
yeah. And they said, come back because your breast tissue is dense, and we just kind of want to follow up. So I had dense breast tissue. They didn't see anything on that initial mammogram, but I was just told to follow up in 6 months.
Thank God, right?
Right.
Abby, tell everybody how old you are. Sorry.
I am 41.
Okay.
I had no history, no family history of breast cancer. I thought
So that was your first mammogram at age 40?
Yes, my second one, right? So I had the first one in 2019, and then I was supposed to follow up in March of 2020, and then that was in the midst of COVID, and so it was rescheduled to June of 2020, and that's when I was diagnosed.
So where are you in your treatment right now?
I am on chemo. I have a AC cycle. I just finished the 3rd cycle of AC, and I'm going to have 4 cycles of that. After that, I will have 12 cycles of Taxol.
How you feeling?
Today, good, but obviously every day it's up and down. I'm just looking forward to getting through the AC cycle because I understand that one is more challenging. And yeah, I'm just ready to get the whole thing over with.
And then when you have surgery?
Yes, I already had surgery. I had a bilateral mastectomy on July 28th. Initially, I was diagnosed with stage 1, but after surgery, there was 1 lymph node positive. So I was up to a stage 2. And I believe that was why chemo was recommended because of the positive lymph node. Yeah.
And what kind of breast cancer do you have?
ER positive, PR positive, and HER2 negative. Did I say that right?
Yes. And I love that you did because the subtype is so important and we don't always know. Those letters don't mean a lot to us, but they mean a whole lot as far as how your treatment goes.
Yeah.
So yeah.
And Abby, you really brought out a very good point for all women to know is that actually the majority of women who are diagnosed with breast cancer each year will not have a family history. So 75% will not have that family history. So while knowing if you have a family history is important, we never want to assume that we're okay or we're safe because we don't have a family history.
Right. Did you feel a lump or you just went back for the mammo?
So I think when I was in 2015, I was 38, 36, 30, somewhere there. I did feel a lump, but it was benign. So I had gone for a mammogram in my 30s. So I always sort of had a lump, but since that first time when they said it was benign, a lump itself did not necessarily scare me. So, but I did feel a lump after March of 2020 this year. There was a lump in there. So yes.
So docs, how do we help women know what to do? So everybody needs to do a self-exam every month. Everybody needs to know you're normal. Everybody needs to get a risk assessment before you're 30. And how do I do that? I want to get a risk assessment. I'm 28. I don't have a history, or I do have a history. What do I do? Who do I call? My GP doctor, Dr. Hampton, or like, who do I call to do a risk assessment?
Yeah, I think if you want to get a true, like a in-depth risk assessment, then you should go to a breast center. Most breast centers have a risk assessment program where it's created to evaluate women, to really dive deep into the family history and to create that printout of the risk. And then they can get recommendations from there. And again, I think that takes a lot of advocating, because the primary care doctors may say, oh, well, you don't have a family history. But again, let's advocate for ourselves. And if you go in and the risk shows low, okay, then you've done everything that you can do. But I'd rather you come in and we find out that you're low risk versus you not come in and it turns out that you're high risk.
Well, my daughter, Amanda, she's now had 2 babies, but she went at age, 29 to her OBGYN and said, my mom had triple negative. I want to be checked out. And she had to fight to get, and, like screaming, man, just yell at them hard and yell some more, whatever, till you get it. But she eventually got pregnant, couldn't even do it. But I mean, it wasn't easy. And she does have a history.
Yeah.
And we don't have BRCA, but so I think that in these circumstances, we really do have to stand up for ourselves. And it's just a shame that we have to do that, and fight for ourselves, but we do. And young women, especially so many young Black women, are getting dismissed. And what if Abby had gone, kind of forced the issue 6 months ago? What if she had a biopsy then? Would it have been different? We don't know, right?
And I think another thing, and I don't know that any of us can do anything about this, but it's the costs are so prohibitive. Like when I went for the mammogram and I was referred to the breast surgeon, even though I had insurance, I ended up with like an $1,100 copay. And in my mind, I kind of was ready to dismiss it. I was like, okay, I have breast dense tissue. This isn't anything. I don't want to end up with another $1,100 copay. But my husband insisted that I go for that, the 6 months checkup. But it's the cost is, it deters a lot of people from following up, because it gets expensive, even with insurance, not to talk of people that don't have health insurance.
I think that's a really good point, because once you have the screener, if something is found, it's now diagnostic, right? And Dr. Nina talked about this before, and diagnostics not covered under the screening in the same way. So the copay, the deductible, all those things, need to be taken into account, especially as open enrollment is coming up. Look at these plans carefully and think about what your plan needs to be, because we have to plan for the unexpected, and it's so unfortunate how insurance is coupled with our jobs, because we have seen that during, the coronavirus pandemic, we have seen people lose not just their jobs, but their health insurance for their families as well. And it's a double devastation. But, Ricky, to your point, I think we just have to, embrace the fact that it's our responsibility to know our bodies to the best that we can, and to take that monthly pause, to check in and do that exam, to hold each other accountable as far as getting those mammograms, buddy up. I know I'm due for mine this month, and my high school has a whole reunion page. And I said, listen, if anybody else needs to go, let's buddy up. Let's be accountability buddies. Treat yourself to something nice afterwards, and put your picture of your treat in the comments. Let's keep this going all year. We'll start in October, but whatever month you're due, let's keep it going. So I'm going to treat myself to a plant that I've had my eye on, because I'm trying to grow my green thumb, and you treat yourself to whatever. And, let's keep each other accountable. But we have to do that. Make it social. When we were able to be social, go get pedicures, go get lunch, do something to help your sisters along, because we're all we have. Black women are going to have to save this planet and each other as we're at it. And I think that we have to stay with that, and make sure that we do, because it is happening. We can talk about prevention, but right now, prevention for us looks like interception. It looks like finding it early. It looks like exercise and drinking our water and reducing our stress, and, trying to keep our bodies as healthy as we can. There's no real magic pill. Dr. Regina, I don't know how many people you see taking the estrogen blockers when they don't have cancer, but a lot of women don't want to take those pills to prevent a cancer they might never get, right?
Right. Yeah. It's hard for me to convince them to take it when, I tell them, look, you have a reason to take it. I can't even take it. So, if you could take that advantage. So it's, that same thing.
And I do want to underscore the economic piece here, because I think it is critically important, because we are talking, when we start looking at the broad tapestry of women of color, we are also talking about women who are socially economic disadvantaged. And so, as we touched on earlier, we know that cost is a factor that's preventing so many of our young, middle-aged, and older Black women from accessing care. So it's important for organizations like Patient Advocate Foundation, others who are in also this patient advocacy space, to really keep at the forefront this whole phrase around financial toxicity. Is not just a catchphrase, it's a reality for so many. And so we really have to push the policy agenda forward so that economics does not become a driving force in terms of whether a woman lives or dies.
Yeah. Right. And if that is your concern, like you've come in for your screening mammogram and a diagnostic mammogram is recommended, and you do have financial concerns over being able to pay or to cover those, definitely let the doctor know, the radiologist, the staff there at the imaging center. We will definitely try to do whatever we can to hook you up with resources if that's a concern. The other thing I wanted to jump on was also what Dr. Mo was saying about, having your mammogram annually, is that, we're busy people, we're working, we're taking care of our family. There's a lot going on. So sometimes, we can forget. So often I will recommend to patients scheduling it around the important date, scheduling it around your birthday, so that you know that each year you have it. Schedule it around your anniversary. Or also, like Dr. Mo brought, getting together with friends, get together with your sisters, get together with your classmates, all go together, go have your mammogram, and then go out for a nice lunch. But that way, having a system in place, so it's not, oh no, I haven't had my mammogram in 3 years,
Right.
But having a system where you can make certain that you remember it.
Right, and have people
Two extra strips Tylenol doesn't hurt either. About an hour beforehand, Doc. That's my secret sauce right there. I tell everybody, ibuprofen not as much because it can make you bleed and bruise, but 2 extra strips Tylenol takes the edge off. I know it's not comfortable. We know it's not comfortable. But guess what? This is something that can help to find things early, help to save your life, help to get you in the self-care routine and practice, that we have to do.
Trust me, it hurts less than cancer.
Wow. And boy, you might drop on that one.
And to also, to help alleviate discomfort is also, pay attention to when you're scheduling it. If you tend to have a lot of breast tenderness, prior to your period, you want to wait till after that time to schedule and have your mammogram. So thinking about those factors can also make it, less discomfort during the exam.
Love that.
Yeah. So how early, I keep telling teenagers they need to be checking their breasts. It's like when you go ask for birth control, you should be checking your breasts, right? So,
and they do that at the places that people are trying to shut down that give out birth control and do breast exams, women and women's health. I can't tell you the number of patients that get sent to me because some doctor did an exam at Planned Parenthood and found a lump, and so we should absolutely be telling our young people about it. Check your breast, check your chest. Because there's a lot of folks who have chest, they're gender non-conforming and non-binary, et cetera. Male breast cancer is a thing. Over 2,000, over 2,600 men this year will be diagnosed with breast cancer.
Yeah.
So definitely.
And often at a later stage because, they're not checking the area or they're saying, men don't get breast cancer.
Right. But they die at a 66% higher rate than white men. Black men do. Wow. Really out there.
So what's hopeful on the horizon? Come on, give me some hope, guys. Let's talk about the things that are to come for us and our sisters.
Dr. Regina and Dr. Mo are going to isolate that Black breast cancer gene. That's what I think is on the horizon.
Right.
That Dr. Watson's going to come up with a new form of breast imaging, right?
And we're all happy. And then breast cancer will be gone and we will all be happy.
Women will save the world.
I'm going to make sure everybody's not broke.
Right.
I'm working on that one.
There's a lot of technology always going on in breast imaging to make us be able to, be better at what we do and finding those small cancers. 3D mammograms was probably the biggest thing. Now we're looking at AI, artificial intelligence. which will aid the radiologist while they examine the mammogram to be able to pick up on cancers. Also, how they utilize breast MRI, not just in the cancer workup, but in patients who are high risk or patients who have dense breast, and also some changes to the MRI exam to have a shorter exam so that more women will be able to have access to it.
I love that. I order abbreviated MRIs too. And I'm glad you brought up AI, because it's an interesting point. Artificial intelligence is trained on something. It has to be, we call it validated, meaning the systems have to be programmed. And we've seen in the tech world that the systems are not validated and programmed on Black skin, Black features, Black eyes. And so when you look at things like the criminal justice system, AI is not necessarily a good thing for us. But I think in the breast world, we're finding that there are studies that are looking at the density of Black women's breasts, right? And taking that into account, and AI could be helpful for us. There's a clinical trial even, isn't there, that's looking at this maybe?
There's a lot going on in AI. You see it in a lot of European countries now. A lot of it's actually coming to the US. And I think there is a greater awareness now that, breast cancer is not the same in all women, that breast cancer is different in Black women. And if we're going to be able to, decrease the numbers and improve the outcome among Blacks, is that we have to make certain in these studies that Black women are included. That's the only way we're really going to be able to make a difference and even out these outcomes.
Yeah, we say that every show, Dr. Nina, that Black breast cancer is a different disease. We have a total different profile, and we don't believe that we understand our physiology to the extent that we should. That most of the drugs that we have now were tested on Black women, on white women, and Black women were not at the table. And until we get that bottle that says this drug works for Black women, we can't rest.
That bottle, right?
Rest.
I think in the genetics as well. I think
everything. Yeah.
I think there's a different gene out there that we haven't discovered.
Yeah. And it's funny, Dr. Regina, because remember last year we did my gene profile, like last summer. And you called me and you said, okay, Ricky, you don't have any genetic mutations. I said, well, is that good? And you're like, I don't know, because we probably don't have your gene identified yet.
Yeah.
And even looking at genetics testing, you have to remember too that as things go along, we are improving. So if you were tested maybe 10 years ago,
right,
possibly consider getting tested again because technology has improved. We're identifying more genetic mutations and technology is changing.
Yeah. I think it's important to note with the risk scores as well. And I think we'll see in the next 6 months to a year, companies are beginning to validate their risk scores, their risk assessments on Black and brown women as well. So, when some companies will give you a percentage and others won't, because it's only been tested on white women. So they can't give you an accurate percentage of your risk based on your genes. But that is also changing. So when the opportunity to participate in trials that are not drug trials come up for us, we need to be receptive to that, because these are things that can make a huge difference. And it's not, the placebo versus whatever. This is a trial that looks at a different technology that could help, women get breast screening that's better. It could help us figure out, what's a better drug for us, what's going to prolong our lives. And so I think that, transforming that fear into empowerment is where we hopefully can go from here, because we hold the secrets in our genes and our DNA. We hold the secrets.
Right.
And I think that we have to understand.
I'm sorry, Dr. Mel. I have 2 questions from Instagram. I have a history of breast cancer. I had a double mastectomy with no reconstruction. My mother had breast cancer and a few of her sisters as well. No male breast cancer in our family, but I have I have a 19-year-old daughter and a 30-year-old daughter and a 21-year-old son. At what point do I need to have the genetic testing for my children? And do I need to have genetic testing?
Sounds like there needs to be genetic testing. I'd be curious to know what age she was when she was diagnosed.
Okay.
If she was under the age of 50, then she should get tested. even if that happened 20 years ago.
Okay, she was 51, she says.
And then the other side of that is if she was under the age of 60 and had triple negative breast cancer, she qualifies to get tested.
Okay.
It sounds like with family history, there's a lot of family history going on. It sounds like there needs to be, some conversation with a risk assessment counselor, a genetic counselor, so that they can really drill down on those cancers, drill down on the ages, and figure out who needs to be tested.
Okay.
You guys touched on so many things that we're going to talk about this month, and we're like over an hour. But so Wednesday we have we're going to talk about male breast cancer with Matthew Knowles. So tune in, and we're trying to get Beyonce to tweet us. So you guys can tweet Beyonce. But
Beyonce had her BRCA test. I'm so curious.
I know, right?
I want to ask, but I don't know if we can.
Ask it. Because they have to, right? Both of them.
I wait for Wednesday because I'm going to be on pins and needles to see Dr. Mo get him up in her corner of the screen and be like, well, really? But tell me, I can't wait because
I'm gonna be on my best behavior because I don't want
you.
The beehive is real,
I think it's going to be amazing, especially now. Because men think that they are so far removed from certain things. And this couldn't be further from the truth. I had a gentleman who knows a friend of mine on Facebook, and he has a female friend. This guy had breast cancer, but he has a newly diagnosed female friend who's afraid to take her tamoxifen. And everybody who knows me knows that I say 24 hours a day, tamoxifen is worse than cancer. I don't care tamoxifen is the worst drug, but we need it. So guess what we do? We take it. And he was saying that she didn't want to take it and she wasn't going to get it. And I was like, oh, if she's looking for me to tell her no, not to take it, it's not going to happen. But, we've only scratched the surface.
Right.
Literally scratch. And I mean, 100% when I say I'm waiting for Dr. Regina and Dr. Mo to isolate this gene, because I know that I know it's going to happen. And I know, Lord willing, and the creek don't rise, we'll all be here to see it,
We'll see it. Yeah.
I think also we need more celebrity advocates. When you look at
high profile
women of color who are breast cancer survivors who share their stories versus white women.
Right.
They'll share their story, which is great. But, if we could find more and kind of get away from this traditional secrecy that we have in our culture.
Right.
It really just changed the game. And that's why I mentioned Beyonce, because I'm really curious to know if Beyonce is BRCA positive. Because can you all imagine?
Right.
Change this whole conversation if Beyonce were BRCA positive.
Absolutely.
Sharing that.
If one of them would get on and say, if one of them would go do a commercial or come on one of our webinars and say, we need to check our breasts, everybody will be setting an alarm to check if Beyonce said it, but it's not enough for your GP or your GYN or your aunt
or your mother.
Or your mother.
But it isn't even about whether she has BRCA or not. It's the fact that she actually got tested.
She got tested.
Right.
So
absolutely.
And to your point,
at least she took the precaution to get tested. When Angelina Jolie did her whole thing, whatever, a few years ago, a lot of people stood up, and a lot of Jewish women realized they had BRCA.
Uh-huh.
It's a great thing.
Very
so
true.
we want a Beyonce tweet. So we're going to do that
Anytime
on
you're
Wednesday.
You guys.
And I have another question too. We're doing the HBCU thing for the next 2 months, and we have two young ladies, and one of them said, "Well, what if somebody asks me about breast exams?" So we added into their media packet information on how to do a breast exam, but it's scary knowing that you're in your second or third year of college and you either don't know how to do a breast exam,
Never heard of it.
or you don't. Either way, it's scary.
Yeah. Yep. So
We have to normalize it for them.
we have interns on 5 HBCU campuses for the next month talking about breast health. So that's so important, right? And then next Sunday, we're actually going to do a special episode called What's Your Her Story and talk about family histories and help them. We're going to talk to a family, a mom, a daughter, and an auntie, and talk about how they brought the breast cancer conversation to their kitchen table, to talk about it with their family and what tools we can offer people to sort of bring up that conversation. So a lot going on this month. We're going to talk about clinical trials at the end of the month. We're going to talk about the flat revolution. So stay with us. We're going to be on Sundays at 3. Thank you, blackdoctor.org. And our normal Wednesdays at 6. We have an action-packed month. And I just put in the chat, at the end of the month, we're going to do a Halloween walk. On Halloween, we're going to do walk your dog. We're going to give prizes to the cutest costumes for you and your dog. We're walking for bone health. Walking is going to keep us healthy, keep our bones strong. So walk with us. We're going to do it live here on blackdoctor.org on Halloween. So get your costumes ready. And then also, we're doing a campaign. So every weekday at 3:00, we're doing a dance break. So we'll put the Zoom link in the chat, or just tune into our Facebook Live at Touch BBCA for 5 minutes. One song. We're just going to work it out from 3 to 3:05 every day and work out. We're going to
and it's no judgment zone. So
no judgment. If you want
no
to
judgment zone. Everybody loves to see pixie dance, and it's not that kind of pixie dance. It's definitely very subdued. I don't have on my wigs and jewelry. I'm just dancing to get up out of that chair like you need to
5 minutes. 5 minutes.
5 minutes and exercise, dancing, and promoting very good bone health.
Yeah.
On the issue of celebrity awareness, this might have come up before I came on the call. Are you guys aware that Ananda Lewis?
Yes.
Okay. Did you guys discuss it already?
No, we haven't discussed that today.
Okay.
Yeah.
But she might be, she might be someone, perhaps. I know that she did post live talking about people, women checking their breasts. I think she's stage 3, she announced.
Yeah, she did. Yeah. We talked about her yesterday, so we can talk about that. But hopefully she can make a statement to young women to check their breasts and be aware.
Yeah. I would also say, Abo, and I apologize if I mispronounced your name, don't minimize the power of your story in terms of its relatability to all of the women who are probably watching this on Facebook. Right. You may actually be able to reach far more women than some of the celebrities that we think. So if we can start to get other young women like you to elevate their power and realize the power of their lived experience and create a space for that lived experience to come forth. There is so when Dr. Mo said about the horizon, what I see over the horizon is our beautiful Black women who are survivors showing that you can survive this. You're not alone in this, and amplifying your voice in a way. I see this as being the most electrifying and most powerful story that we can tell to really mobilize an entire movement of women to understand that their breast health is just as important as everything else that they're trying to balance in their life. Right. So amplify your voice, because you might start the movement.
I love it.
Yeah, I know that I told her we're putting her to work. As soon as she gets done with her chemo, she's going to work.
Yes, and I am more than willing to do that. I definitely am.
You applaud your courage.
Yeah.
Yeah, because she has 2 young kids, and she's
3 actually.
Oh, yeah, 3 kids.
Yeah, 3
How old are your kids?
And a husband.
Yeah, my oldest is 14. And I have a 12-year-old and then an 8-year-old.
So you're dealing with life.
Yeah.
Because policymakers need to understand that there are real people at the end of these sorts of things.
I remember, Abby, when I called you, I think you had just gotten home from being discharged from your procedure. Can't remember, was it that same day?
I think it was when I met with my medical oncologist.
That's what it was.
Yes.
Her kids were, what do you want me to do? Do you need me to feed you? Do you need-" And it was just like, I was like, can you send one of them down here? We'll come and get-" And we were joking, we were saying, we're here to do whatever you need us to do. I know you're not in this area, but you never know when you may, but so feel free to call us. And Ricky always wants to take somebody's child or dog. He'll come and get the kids. And the kids were in the background, literally waiting on you hand and foot. And I thought, that's
Everything. And you're blessed to have that.
absolutely wonderful.
I think we have to get ready to wrap up, but I want to end right there with what Shanta said, is that, this is a revolution, and it can be for us. We have seen through Touch and through this program, we've seen us partner with every breast cancer organization, especially those committed to Black breast cancer. Every organization that there is now linked in to this network and tuned in, tapped in, and turned on, as Esther Hicks says, about Black breast cancer and bringing us together and amplifying those voices and those stories. So thank you all for sharing.
We want everybody to come into our sandbox and march down the yellow brick road to get rid of this. So
that's right. This is all love, and it's all sisterhood, and we have to save ourselves, and we will. We can and we will.
We will.
And so can you tell us, Dr. Nina and Dr. Hampton, and anyone else, how people can reach you, follow you on social media handles, etc. Real quick round robin, and then we're going to close out.
So I can be followed on all forms of social media as Dr. Nina Watson. So DrNina Watson.
Great.
I'm on all social media as well. You can find me on my website, drreginahampton.com, which will link you to all the other organizations that I'm involved with.
And I forgot to say that when you were saying do something nice for yourself, go to her store, check out cherryblossomintimates.com.
Oh, yeah.
You'll find something nice for yourself. And she has beautiful, beautiful lingerie and products for all women, but especially for women who've had surgery. And she makes you feel like a princess when you go in there. So if you're in the DC area, check it out. It's worth the trip. Or if you're not, you can go online and buy beautiful, beautiful things that will make you feel very pretty and beautiful.
Can I add one more quick thing about Cherry Blossoms? Probably 2 weeks, and I probably shouldn't say this out loud in front of Dr. Mo and Dr. Regina. I want to say maybe 2 weeks after my procedure, Jasmine reached out and said, Terry, come in and just to see, we'll give you a new bra holder for your tubes, for your J tube. And I was like, no, I really don't feel like it. So I went anyway. And she made me feel like I was a princess. It was just the most serene,
beautiful
atmosphere. It was unbelievable. So much so, I take my shoes off only when I'm comfortable. I was in the store. There's a picture of Jasmine and I with my shoes off, and I'm standing on the floor. But it was, ladies, if you have never been, you are in for a treat. We're
actually going to do this show from there on November 4th.
Right, on November 4th. But they have everything you could possibly and not possibly imagine or want. You would be, you so much, the swimsuits for us flats. I mean, everything that you could possibly imagine.
Lots of love and lots of love.
I told the breast cancer groups to take a trip down there, before COVID. But when outside opens back up, it is a great day trip to take with your survivor support circles, because you can get some lunch, you can treat yourself, make yourself feel wonderfully special, help out other women, and just really fellowship with each other and support that amazing, amazing business. So
we may be coming to Atlanta soon.
I actually live in Atlanta, so come on.
All right.
Listen, come on up to Philly. You said nothing. Come on up.
Very inexpensive. They are affordable. Everything in there was very affordable and worth whatever the price was.
Oh, thank you, ladies.
I loved it there.
Yeah. So I guess we should sign off. We're really over time today. Thank you, Doctor. Thank you to our sponsors. Amgen, we love you. Genentech, thank you for sponsoring for the month of October, and we appreciate you guys, and thank you so much. I love you guys so.
Yeah, thank you all. Dr. Monique Gary.
Best love.
Yep, the doctor's in.
Dr.
Take
Din.
care.
Take care.
Gary Blasker.
See you Wednesday. Matthew Knowles.
Matthew Knowles.
Tune in Wednesday.
Wednesday night.
Wednesday night.